Thank you all so much for coming. I appreciate it. You spending your Thursdays with us. And this is our third Thursday Trauma Talk. Appreciate you being here with us. I am honored and privileged to have Dr. Ken Mattox and Dr. Lance Stuke here to discuss the resuscitation of the trauma patient pre-hospital. Dr. Ken Mattox, obviously, he is world renowned as an educator, and literally wrote the book on trauma. He's been at Ben Taub for decades, and is especially he's world renowned for his innovative leadership, and with trauma care. Lance Stuke has started his career as a paramedic on the streets of New Orleans. He worked his way through medical school. He went on, did his residency at Parkland, returned to New Orleans to do his fellowship, and now faculty at LSU. Dr. Mattox, you had mentioned in our first trauma talk in August that resuscitation of the trauma patient pre-hospital is a hot topic and something that we needed to discuss within this forum. And so I'd ask you to lead off this discussion.
All right, I'm going to pass to Dr. Stuke and ask for the definition, his definition of resuscitation, because I don't think we haven't taken a deep dive into what we're trying to debate with resuscitation. And I think resuscitation has been associated with as good a blood pressure as we can get, even if it's double that of the pre-injury systolic blood pressure. So that's just to start the discussion. So Dr. Stuke, what is resuscitation in EMS and the pre-hospital?
Right. So good. That's a good way to start this, because we don't know the answer in the ICU yet. So I think it's going to be a really tough question to answer pre-hospital. I think the medic should have the goal of arriving to the hospital, to the correct hospital, to a trauma center if available, with a patient with a perfusing pressure to the point where they can mentate. And that pressure is probably in the range of 80 to 90 millimeters of mercury, no more. And I would not advocate for less. And as rapidly as possible. So scene time of 10 minutes or less, I would advocate 5 minutes or less. And my bias now is to use blood products. I don't think TXA helps, but I do think blood products are making a difference. We're seeing that in New Orleans. I think San Antonio has shown early good results as well. So it's a difficult question to answer what parameters you look for, but I think if we can get the patient to the hospital, to a trauma center, with a mentating blood pressure of around 80 to 90 systolic, I think that would be the goal. Just to keep it as simple as possible for the medic.
I love that. We're in total agreement with in that definition. I think 80 to 90 is okay as a systolic. Ironically, that's when you can feel a pedal pulse. Less than 80, you can't feel a pedal pulse. And above 100, the pedal pulse you can feel, but it isn't differentiating it. So if there's a pedal pulse, I wouldn't push any fluid. A couple of things to let you know. There have been studies in pigs and in people that if you get to the pre-hospital blood pressure and higher, you actually, especially in the pre-hospital, you pop the clot and you bleed more and the mortality rate goes up. Whether you increase that pressure with MAST or vasopressors or lots of fluid. Remember when all of this started, all of us were giving 3 liters of crystalloid in the ambulance, 3 liters of crystalloid in the emergency room. And then we wondered why when we gave the third 3 liters, in the operating room, their blood looked like strawberry Kool-Aid. So what you've heard Lance say, I think is a good foundation, and that's been shown in the pig. The pig model with the weight close to a human model, they popped the clot at 80. And that was done at the Institute of Surgical Research in San Antonio. And you use the other magic word when you didn't really say blood pressure, you said perfusion. And so we're in agreement towards that goal. We have a lot of educating to do on both pre-hospital and emergency physicians, because there's 2 or 3 reflexes that we, all of us here, were responsible for starting back when there was nothing. Remember when Norm and I were in medical school and residencies, EMS, emergency medicine, emergency trauma centers, many of the antibiotics we have now, fractionated blood did not exist. Helicopters did not exist. Informed consent did not exist. So in an attempt to get there, we may have overshot, and now we have to take some habits away. And one of the big enemies right now of trauma surgeons is emergency physicians, who still drank the original Kool-Aid, but haven't kept up with some of the scary new thoughts.
We do have.
Oh, good, Mary. Can I throw a question back to Dr. Mattox real quick, though?
Please.
With the increasing use of pre-hospital blood, would you change your parameters, or are they still a pressure of around 80 and maintaining?
No, I'd go to 80 and that's it. If they have a pedal pulse, I would not give any pre-hospital blood. So when even the people that talk about pre-hospital blood don't talk about endpoints of resuscitation, because if you ask them that, they suddenly start talking out of their ears, and the words don't mean anything.
We do have a question from Andrew. Is TXA still indicated in pre-hospital mass hemorrhage?
Only one indication. That one indication that I will admit to is if you're trying to make money and own stock in the company that makes TXA. I think TXA and the studies were poorly designed, and I don't know that it does anything except make money for the company that makes it. Now, Lance may have a different idea.
I totally agree. I think, if you look at the CRASH 2 trial, the number needed to treat was 67, and in Matters, I think it was down to 7 or 10, but the CRASH 2 trial had so many problems, and those authors have done good work, but I think they are trying to find studies to support their preconceived conclusions. And we can't remember to use TXA in the hospital at the trauma center. We forget now we only give TXA if TEG supports it, and I don't think it has made a difference pre-hospital.
To kind of go back to the topic about resuscitation of the trauma patient pre-hospital, it was 30 years ago, but Daddy said dead is dead. If it's dead, if a trauma patient is dead on the scene, I'm not sure what the expectation is to do CPR and transport that patient to the hospital.
Stop. You do what? See what?
If dead is dead, dead is dead on the scene.
Use an abbreviation I didn't recognize. CP what?
Exactly. There's no point in using CPR in a pre-hospital setting on a trauma patient.
Your dad said that?
He drew it out on a sheet in the charity emergency room. Dead is dead on the scene of a penetrating trauma patient. There's nothing else to do.
So we're talking about penetrating trauma, not stroke, not heart attack, not, okay. I totally agree with that. And that was the next subject I was going to bring up is CPR in the ambulance or in the emergency room in penetrating trauma, maybe even blunt trauma, actually makes things worse and decreases the chances that we're going to save somebody. And so all of our hands have been trained in the hospital. If we don't feel a pulse, move right to the sternum and start pounding.
Dr. Stuke, why is this such a hot topic now?
I don't know that it's a hot topic yet. It may be down the road. There is some early research on this subject. I have a problem with the concept fundamentally because as a medic, speaking as a former medic, what are you going to do? You can give blood to a corpse, I guess. You can intubate the corpse if you believe that they should have an airway. I'm not sure I believe that for traumatic cardiac arrest. But if you're going to pick up the corpse and drive them to the hospital where resuscitation begins, I have fundamentally just a tough time wrapping my head around that concept. I understand physiologically why CPR worsens the bleeding, what little blood may be left, but I'm not ready to step out and say that we should teach our medics to scoop and run, but not do anything en route. It makes me uncomfortable to say that.
Suppose using a Da Vinci technology without the big Da Vinci machine, I could teach a paramedic to insert a probe and lacerate the pericardium anterior to the phrenic nerve, and through that scope, suck out the pericardium that you can't do with a needle. Would you, we have talked about doing that in Houston, because once there's tamponade, pumping on the chest doesn't do anything. Needle aspiration doesn't do anything. It's all clotted already. But if you lacerated the pericardium in a large enough laceration to suck out a big clot, you might have more bleeding from the heart, but at least you have a chance, especially if the time is short.
You might. My counter argument to that is the real world reality that most urban EMS services can't afford Curlex gauze. And now we're going to try to get them to pay for this technology. I don't know that, number one, I don't know that it's feasible financially. Number two, I don't think it's realistic. I'm nervous now teaching paramedics to do needle decompressions and other pre-hospital interventions. I don't think they get adequate training to do it. So this next step scares me even more. There's the technical imperative of the paramedic that you learn a new skill and then every patient suddenly has that indication. And we're seeing that in New Orleans now, specifically with needle decompressions being done too often and incorrectly and not for the right indication. So I have a bit of a concern taking that leap to teach the medics that next step. And the biggest issue I think is just financial. Most EMS services can't afford it. And then third, what does it do to the scene time? It doesn't fix the problem, it prolongs the issue. And if you're in an urban setting where the nearest trauma center is 5 to 8 minutes away, is it worth sitting on scene to do this?
If you don't mind, I'm going to pull Allison Smith. She's a physician with LSU, and I see that she's here. She's like not like a week postpartum. But Dr. Smith, is there does it sound like it's more of a stay and play from an EMS standpoint rather than go to the hospital? What's your feeling about resuscitation pre-hospital?
Hey, Mary, 6 days post-delivery. Sorry, still I have a baby laying on top of me right now. So yeah, I mean, from my standpoint, I think what I've seen, at least here and in San Antonio, there's a lot more of a stay and play mentality. And I think it's just because there's definitely a lot more push to add additional adjunct treatments that EMS can perform, you know, in addition to blood, especially here in San Antonio has a huge whole blood pre-hospital program. We've talked about needle thoracostomies, and there's even been talks of crikes and other things. So I definitely think that, you know, there's definitely been a shift, at least depending on the EMS company, to kind of a stay and play mentality. But that being said, we did do a study where we looked at rural EMS companies in North Dakota. We compared it to our data, and definitely from their perspective, because it seems like, you know, the medics there are a lot more volunteer. There's not really as many actual paramedics in that setting, even though they have very long transport times. They're a lot more of the just like get them out of there, like the scoop and run, even though it takes them sometimes up to 4 hours with transport times. So I think it's definitely an evolution in certain places, but especially in the urban setting.
Can I throw the question back real quick to Dr. Mattox? Because right now you can't turn on the news without seeing the Queen's funeral and talking about the royals. So it brings me back to the Princess Diana treatment that she received in Paris. And it sounds like a lot of what you're discussing is, you know, 20 years from now in the US, our medics could be doing something similar on the scene where they stay and play. Is that, you know, what are your thoughts on her treatment? And then do you think that's something that we'll be doing in the US in 20 years?
She got many liters of crystalloid, and she also got huge doses of epinephrine before they even left the scene, because that was the philosophy then, as it still is in many countries in Europe and the Middle East. She had a very rare condition, which was a herniation of the heart, and had somebody even done a physical exam, they would have found the pulsations in the heart on the right side, and said, this is something wrong. Even in the emergency room, they did not do that. And they thought all this was a hemothorax, which it was not. I think, I don't know how many of you have ridden in a Tesla, but the electric cars are, especially with good suspension, not as bumpy as one with an engine that's shifting gears all the time. I could propose that this could be done while moving, or some things could be done while moving, as long as we don't do too much. So part of this is we need a congressional Congress to go back to the drawing board, where a large group of decision makers in emergency medicine, EMS, trauma, and even bring some OB and pediatric and cardiologists, because there are times when a pericardiocentesis is indicated in someone who's uremic, tuberculosis, other cancer, hemopericardium. But then we get all hung up on things like ultrasound, where people go just ape crazy and try to extend it to areas that it doesn't help them at all. Remember that what we do ought to either change the patient's condition or change our decision-making, and taking time on how long was the pre-hospital CPR is a simple thing that does change our decision-making. If it's been 2 minutes and there's still electricity, although no output on the EKG, every one of us is going to cut. On the other hand, if there is no pulse, it's a 45-minute ride to the hospital, and they're doing CPR the whole time, every one of us will declare them DOA. Now, there's areas where we can build on our agreements. And part of where we are is ego. Now, I know paramedics, EMTs, emergency physicians don't have big egos, but surgeons have the world's largest concentration of mass raw ego.
Absolutely. Dr. Cromer, can you weigh in at all on this subject? Would you like to?
Yeah,
Throw
I'll chime in on a couple of things. It's interesting that you brought up the Lady Diana case. I was actually the chair of the ASAP EMS committee at that time, and got a call from CNN asking if I would compare what I thought of the resuscitation and care that Lady Diana received, and wanted to comment on it. I very adamantly refused to, because their EMS system was a physician-based response system. And for her resuscitation, they were,
Anesthesiologist.
well, that's what I was going to say. For her resuscitation, her response, there was an anesthesiologist and an emergency physician, at least as I understand it.
Yes.
Their ambulances were laid out such that the expectation was that you would conduct the resuscitation while you were transporting slowly to the emergency department, because of the bouncing around and things like that. So, you know, I think it, I hadn't heard about the herniated pericardium or cardiac muscle. In terms of the load and go versus stay and play, and I wouldn't be foolish enough to say that this is common around the country. I think that for trauma, there is a general consensus that they should be loaded and on the way to the hospital. If it's a blunt trauma arrest, yeah, they may try and do CPR and resuscitate. If it's a penetrating trauma arrest on the scene, hopefully in the next couple of years, we'll get to the point where everybody just agrees they should not be transported.
Is there an argument to be made with penetrating trauma that they should be transported?
Should or should not?
Is there an argument that that dead penetrating trauma on the scene should be transported at all?
If they're dead,
If
but
they're
if they
dead,
have, if they have a pedal pulse, go.
okay,
And I don't even take a blood pressure in the shock room. People are doing their playing. I walk into the shock room, I feel for a pedal pulse. And if there's not one, I either pick up a knife or I drag the stretcher out into the elevator and head for the OR. And, there's one place in the country, LA, Dimitrialis, and they have a protocol to resuscitate and do whatever they need to do in the pre-hospital phase in order to retrieve organs for organ transplantation. Now, I don't know if the kidneys from that program are good or if the liver is good, and I don't know what organs they use, but he's been at several conferences and said, be very, very aggressive in the ambulance and the emergency room in order to increase the donor pool. I'm not ready to buy that. But
isn't that primarily for blunt trauma though, Dr. Mattox?
I don't remember if he made that differentiation.
Okay.
Actually, I could make an argument that blunt trauma, especially auto pedestrian and auto bike, our worst results right now are in that group of people, and we have more auto pedestrians than we've ever had in a long while. And we also have a lot of people who are road rage shootings, total strangers. This has occurred since COVID and since the courts have gotten very lenient in letting killers go back out on the street, even though they're under bond. So we have a different environment. we have a faster time, especially in urban areas. It opens up the door for lots of research to ask a hard question, get some numbers, and publish them. Remember, Norm and I debated mass pants, and I was beginning to believe maybe we were doing wrong. So we did a study. We pulled a card, and it said yes or no on mass pants on people who had a blood pressure less than 90. And we showed that mass pant application at all levels increased the deaths. And overnight, with hard data that was prospectively randomized, waiver of consent, mass pants disappeared. The world is hungry for data.
Andrew and Brandy, I'm assuming that you work on the streets. Do you have any input as to what as to your experience?
If they don't, Mary, I'd like to make a couple comments.
Steve, go please.
Yeah, I agree with the, Dr. Mattox and Dr. Stuke and everything. And actually, I'm going to bring in Dr. Kramer in this too. I think one of the things that's also, I'm going to talk about two things. One of the things that we need is we needed more aggressive medical directors that oversee some of their EMS organizations in there. Because most of the medics are educated to a checklist protocol system. And that's great if you're a pilot, but I got to tell you, it doesn't work for patients. And all. Every patient is entirely different. We need to educate our paramedics more and more on the pathophysiology of life and death in between there, and the things to know not just when to do something, but when not to do something. It's good to do something, but sometimes it's better not to do something. But that also takes a good, aggressive medical direction in there. I think we've made great strides in the National EMS clinical guidelines in there, and some of the ASAP stuff in there. But after 30 years of being a regulator, I can tell you that most medical directors don't have a clue on what's going on out there in a lot of the services in there. So, and again, I think that has to come from a peer perspective. Not a lot of physicians are going to listen to a paramedic. They're going to listen to the other advocates in there that's at their level. The Dr. Stukes and the Dr. Madisons and the Dr. Kramers of this world in there. And I think that will also help drive things a little bit better in there, and understanding why this patient is exhibiting these signs and symptoms and what we should or should not do for them based on what our current resources are. As Dr. Smith said earlier, in North Dakota, they have different available resources versus Los Angeles versus Houston and things like that. In there. So again, I think, trying to develop this system in there is going to take a lot of moving parts to come together in between there. And I agree with, with the comment in there that sometimes dead is dead, and we need to be able to recognize that and all, and when is the appropriate things in there. We know that we can pump enough fluid into somebody to bring their blood pressure up, but the problem is that fluid doesn't have the blood carrying capability. So then we decrease the energy production. So then we continue to get that triad of death revolving in there, and getting our medics to understand how that is occurring in there and what that is in there, and the medical directors to understand that, and the system that they currently happen to have to accept that also.
Andrew and Brandy, I just want to say that Steve is leading into his talk that he's going to do in Omaha on October 14th. So it should be interesting. Again, Andrew and Brandy, do you have any, what's been your experience on the resuscitation pre-hospital? Andrew?
I think initially when I became a paramedic, it was like we started with just pump them full of fluid, crystalloids, and try to get a permissive hypotension and get them to the hospital. I know in time we found that crystalloids are probably the worst thing to give them. I'm glad I work for a service now that I carry blood on my aircraft. So being able to give whole blood is a good thing. And also go back to the training is back when I was a paramedic, it was CPR for everybody and get them to the hospital. But now we've kind of gone to knowing what the signs and symptoms are, the pathophysiology, and being able to know that either we're too far gone or if we need to transport. But I know a lot of training facilities are still just pumping out paramedics by the numbers instead of teaching them what should be done. It's getting better, but it's not all there yet.
So I got a message from Brandy. So yeah, mass trousers aren't used anymore. But what's been your experience on the streets? As do you code the patients who don't have a pedal pulse pre-hospital?
I'm a recent EMT, so I am not on a squad yet. So I don't have experience. Sorry.
What's
Welcome to
been
the group, though.
Yeah, right. But again, I think what's amazing about this is you talk about this is actually if you go back and look in the EMS educational curriculums and everything, the pedal pulse is not even actually indicated in one of the pulses to check in the patient assessment.
Is it Rick talking about radial pulse instead, Steve?
Yeah, it's radial pulse and carotid pulse and femoral pulse. The three pulses that are dictated in most of the educational EMS educational curriculums in there. And actually, I think if you even go to the and Dr. Kramer can correct me, but I think even in the clinical field guides right now, pedal pulse is not even an indicator in there.
Well, I brought up pedal pulse. I chose pedal pulse because number one, I do a lot of vascular surgery and I'm comfortable with the pedal pulse. Second, when I come to a shock room, it's the paramedics are there, the nurses are there, the emergency physicians are there, the surgical residents are there, and there's no room for me at the head or the chest or the belly or the head because people are there. So the only thing left for me is the feet.
The dirty feet. That shows you the trauma surgeon's place in the world, right?
right?
Right.
So can I throw a question back to you, Dr. Mattox, or to anybody then? If masked pants aren't the answer, what about pre-hospital REBOA?
I love my mother. And she said, if you can't say something good about somebody, don't say anything whatsoever. I could oblige you and say something, but way back before it was REBOA, I used intra-aortic counterpulsating balloons that we use in cardiac surgery. I used something called the precluder, and I really screwed up some iliac arteries, some vena cavas, some aortas, and I killed a bunch of people with those. And I think intravascular control under the right circumstances is a godsend. Injured subclavian arteries, there's a great now new technique that you don't have to make these horrible incisions. I think in the aorta, and I've told this to the company, I've told it to Holcomb, I've told it to all those people who write, we need maybe we need a new device that stops the bleeding by being a double lumen balloon and allows for distal perfusion so you don't get severe acidosis. But I do know some people that are working on that in the laboratory, and that may change the story. But under its current design, for pre-hospital use, for emergency room use, the only people I find that survive REBOA are those who didn't need it to begin with. The Army the military is using it for austere environments, long pre-hospital transports to try to get to, and then they have this thing called a crock, which is a device that they put on the iliac artery for distal bleeding. It seems to me that's a torture device. Some of these need some real work at the Institute for Surgical Research. The concept may be a good one, and we'll be using it in 10, 20 years. But right now, this design is not ready for prime time, in my view. Now, there are some people who who love the Reboa. It's kind of fun to cut down and do it, inflate the balloon, but then what's the results? What comes down the line? Who control? I literally had to break up a fight between a radiologist and a trauma surgeon on who controls the syringe that puts the pressure on or off of the balloon. And because they'd like to play the game.
JP 026, I don't have a name for you, but can you weigh in on the Reboa? Maybe he's not actually there. Allison, what's been your experience with the Reboa?
Well, I'm probably in the opposite camp just because I am a more avid Reboa user. I agree that I think there's still a lot out there we don't know about it, and I think it is still evolving in terms of what the usages are. I'm not really a fan of it for penetrating trauma, but I do think that it can have a role sometimes with blunt trauma and just kind of temporarily, having occlusion of the aorta. So I do like to use it, but I agree that I think there's still a lot we don't know about it.
There's two balloons I think are great to be used in concert, a Reboa and an intrauterine balloon in placenta accreta and other obstetrical catastrophes. And we've probably used the balloon Reboa more there than any place else in our hospital.
Yeah, the same thing in San Antonio. We had a very strong Reboa program for high-risk OB patients in combination with interventional radiology and urology. So it's kind of a multidisciplinary approach, but we've tried to generate something here in New Orleans. The problem for us is we don't have a centralized maternity hospital. So we've reached some struggles just trying to make it happen since our OB is kind of spread out throughout the city.
Andrew, with your flight medic experience, do you use Reboa at all?
Not on the civilian side. I'm also an Army flight medic, and I just came back in 21 from a deployment to Syria, where we trained on the Reboa for either our longer flights or some of the austere long-term care of a patient if need be. So I never used it, but I was trained on how to put them in and monitor and maintain the patients.
Thank you for your service, Andrew. We certainly appreciate your being out there. Thank you for your service. Dr. Cromer, can you weigh in?
Actually, no. I mean, there are a couple of EMS systems that have talked about initiating Reboa programs. I don't know if they've operationalized it yet. And candidly, I've been out of the emergency department long enough that it didn't exist when I was taking care of patients.
I think it'd be tough hospital, Mary. I think it'd be tough. The arterial stick is challenging, especially in a hypotensive, hypovolemic patient. We in the trauma bay, we usually use ultrasound to help find it if we can't palpate it because it's just usually not there. And then there's the issue of confirmation of placement. In an average size adult, you know where to go, how far to insert it before you inflate it. But most people nowadays are not average size, so that makes it another challenge. And then we have a lot of complications, and Dr. Mattox alluded to that too. But we have these are placed by senior surgery residents or the trauma attending, and we have a lot of vascular injuries that later need repair.
Go ahead, Dr. Mattox.
If you give me a knife and I cut the fascia of the belt large enough to get my hand in, I can reach the aorta and put pressure on with my fingers, and I can be on the aorta in something like 7 to 12 seconds once I pick up that knife. And while I'm holding the aorta, if somebody wants to slide in a Reboa, maybe we can have a hybrid process. But I also have the pressure on the aorta and can calibrate what the blood pressure is. And maybe we ought to back off on the fluids. Maybe, the art of grabbing the aorta with the hand, the best results in the world were obtained in the 70s and 80s in San Francisco, Los Angeles, Dallas, Houston, and a few other places. And they had surgeons that were really adept at getting to the aorta quick and then deciding what to do. And various things and various approaches were used. There's now a bunch of wimpy young surgeons who I think are afraid to operate, and they're looking for reasons not to operate. And they radiate the hell out of people with CT that really need a hey diddle diddle right down the middle abdominal system.
Daddy loved nothing better than a gunshot wound aorta. I'm just saying, when I was on the streets, and to every medic, certainly Lance can attest, it was all about the gunshot wound aorta.
Yep.
Just sort of refocus a little bit, just with the few minutes that we have left. Andrew and Brandy are from Nebraska. And so one of the subjects that y'all had touched on, that we're going to have a talk about in Nebraska, in Omaha, is the point of care ultrasound. Can Dr. Mattox, Dr. Stuke, Dr. Cromer, can you weigh in on the POCUS pre-hospital?
For ultrasound,
Yes.
I don't think it has a place.
Okay.
I don't either. Especially doing a fast exam pre-hospital, that's one of those things it can be done so quickly and can be repeated on arrival. It's user dependent. And so to be proficient at it, you have to do it a lot. And most medics, I don't think would have enough exposure to do enough ultrasounds repeatedly to maintain proficiency. We have trouble keeping residents proficient. So I don't know that it has an application as of now pre-hospital. Dr. Comer may disagree. I'd like to hear what you have to say.
Yeah, the biggest thing that and pre-hospital ultrasound is really getting a lot of attention right now. The three things they look for: there are some systems that will do fast exams, the others will look for pneumothoraces and any type of cardiac motion activity in arrests.
Actually, oversaw
some-
a couple pilot programs for the use of POCUS in the pre-hospital care. And again, the other thing that came up too that was interesting is there wasn't a surgeon around that would accept a POCUS exam that was done by a pre-hospital provider. So it was repeated again once it came into the institution. So again, it was almost another one of those waste of time. And one of the most common things that it was being used for was IV placement.
I was just going to
Does that
comment
hurt?
on
Does that hurt
There
your
are
heart, Steve?
some systems that do
No.
use it for IV placement, and my response is why.
Why?
Yeah, that's what I said. It's an expensive toy. Actually, we looked at trying to train astronauts to use ultrasounds back in 2000 in the space program with and everything, and it was determined that it was a waste of time in there.
Andrew, have you had any experience with using ultrasound pre-hospital?
I've seen it. We did a little bit of training in the military with it, but I think for pre-hospital wise as a paramedic, the data that I'd gained from a POCUS exam wouldn't drive my clinical course anyway. So I think it's useless in the field. It's cool. It's a neat tech. I love tech, but I think it'd be something else that we would spend way too much time on seeing, trying to do a fast exam that I do 3 of them a year, and it wouldn't give the patient any benefit.
Well, we are going to have a talk about it in Omaha, Nebraska on October 14th, and we will also have a panel discussion about it in the afternoon. So Brandy and Andrew, please join us for that conference. And so any other questions or
Mary,
suggestions?
I just would
Yes.
like to follow up on our the conversation that really started and show you a quick slide, actually
Please.
2 slides. Madison or Mary, can I share?
Yeah, share screen. Okay, I think I did it. Did that work?
Yes.
Yes.
Are you
Yep.
are
Yeah,
you seeing
got
it?
it.
Yes.
Okay.
Wow.
In follow-up to drones, this is a drone in the Netherlands that delivers an automatic external defibrillator on the upper left. This is a drone that was used by, I think, the University of Texas at San Antonio in their disaster program to investigate the possibility of delivering blood and other disaster supplies in hard to access areas. The lower left is a mock-up. It is totally a mock-up, but was actually used during a disaster drill of a potential drone ambulance. And this is a similar schematic. So the folks are thinking about them and looking at them. This is from a couple of months ago, and admittedly, I don't know what the current status is, but this was a non-operational mock-up of an ambulance drone that they had developed in Israel. It's out there.
Well, Dr. Mattox, I can see with your experience with drones and Dr. Crone, your experience, then we're looking at another trauma talk between the two of you about drones and drone use and the future of it.
It has potential for blood delivery in
Yes.
the urban areas.
Right.
Legit.
Well, and I think, back to what Dr. Mattox was talking about earlier and everything, as an EMS provider and everything, we know that probably 60% of our calls are what we refer to as routine calls, more of a transport, where a drone system could utilize, could help with that to keep your medics in a position to respond to some of the more emergent calls and everything in there. But a lot of the transports, especially within the urban areas, are not necessarily a paramedic level call in there. It's more of a transport system.
Yeah, there have actually been discussions subsequent to the pandemic about using drones to deliver telehealth capabilities.
Yes.
Let me move to another subject. The number one admissions to our emergency room are falls from standing in elderly patients. And I am aware in Houston that a huge number of Houston Fire Department ambulance calls are for old people living alone who have a phone in their pocket and they fall and can't get up. I take my hat off and compliment paramedics who make a judgment on, do we leave this old person who now has a little bruise, may even have a little laceration, and put them back to bed because they don't want to go to the hospital. They know it's going to be a 18-hour run. So a huge future topic is not the big bad bleeding shotgun wound to the aorta, but it's going to be decision making on when you don't do something to somebody and put them back to bed, and focusing on the elderly patient who fell, can't get up, and has something going on with them. To me, that is a huge, huge big black hole.
Mhm.
Dr. Mattox, I agree with you. And again, I go back to what I was saying about the medical directors being able to accept that responsibility for to allow the EMS providers to make that clinical judgment in there based on an assessment of the individual and not a checklist protocol in between there, but an assessment of the individual and the resources that's available in there. I agree with you wholeheartedly. All of us can think about the numerous times that a patient was transported just for the sake of transporting them when they did not need it, when they could have been taken care of right at their own residence in there.
Fred, can you weigh in at all?
Sure. Yeah. Just one comment as I'm listening to all this. It's really refreshing to me that this entire conversation has been clinically driven. For those of us who started a long time ago, I started in the 70s. A lot of our protocols were developed. I know you have, Steve. Were just as much medical, legally driven as they were clinically driven. That's
Yes.
one big change. Now it's really about what works and what doesn't work. not so much what you should do or shouldn't do for some other extemporaneous reason. Getting somebody off scene, for example, or not getting sued for not transporting the guy who had been impaled by a steering wheel or whatever. That's one big change. The other big change for me is the advent of EMS related data over the last however many years. For a long time, we really didn't know what we were doing, what was working, what wasn't working with the handwritten patient care reports and that kind of thing. And really, over maybe the last 20 years or so, we've developed much more robust EMS data systems that relate to hospital systems, that relate to outcome data and all that sort of thing. So all these decisions we make about what we should do or should not do as field providers is much more clinically and data driven. And I think that's a really positive thing. And that's been a change just over the time of my career.
And part of the, well, sorry, go ahead, Dr. Mattox.
What's this thing called that we're doing tonight?
It's the third Thursday trauma talk.
Does it have Norm's name on it or your name on it?
McSwain, it's part of the McSwain Trauma Education Project. It is,
Okay.
yes, it's
I have an assignment. I have an assignment.
yes, sir. I have a
There
pen.
there are 12 people remaining on this talk.
Yes, sir.
Each of them have their own favorite social network experience. It could be Facebook, it could be something on WhatsApp, it could be Twitter. I recommend that every one of those 12 write up a summary of what went on tonight and some of these things that were rumor that now are no longer, things that have been reinforced, and a number of places where we ought to go from here. And so the reader will say to themselves, shame on me for not being there. Others are coming up in the future, but using multiple social media sources to say what was your impression of this meeting. I thought this was very, very healthy, and I thought we did not let emotion get in the way of our brain moving in all sorts of directions.
And to Fred's point, it's clinical, and that's what we expect and what we want out of these discussions. And Dr. Mattox, you bring up something that's very important, and we do send out surveys after the trauma talk as to what was good, what would you have rather, talks that you would want to hear in the future, but we probably don't utilize social media with those evaluations as much as we can, but we will. And certainly appreciate Andrew and Brandy and JP and iPhone's participation in tonight. Of course, Fred, as always, and Dr. Cromer is always a welcomed guest. We're going to get you on as a speaker very soon. So were there any questions?
Thank you.
I have a couple of comments. One, it's the top of the 8th, and Houston is beating Oakland 5-2. And so that's good. Go Houston in the World Series. Second, there is a hurricane out there about to hit Puerto Rico, and it can't make up its mind on whether it goes to Cuba or it goes to Florida. And there's a possibility that Florida, the Gulf Coast, Houston, New Orleans could get hit. This is the longest time in my lifetime when a major hurricane has not hit the United States on either the East Coast or somewhere along the Gulf, or games that Norman and I always played when they hit the Gulf. Is it going to go to New Orleans? Is it going to go to Houston? And that was the whole Katrina thing. And so we're still in the hurricane season. You all be safe and be prepared, and have your own rescue bag, but be ready to do what we need to do for our patients.
And on that point, I was to your second point first. Madison has been on me about ordering pens and folders, and so they will be in the next week. So she's been concerned about hurricane season and getting things ordered and done for Omaha and Cancun. And then so Ken, to your first point, that's basketball, and it's about football season now. And Roll Tide, University of Alabama.
Yeah.
I am looking forward to the LSU Tulane game.
Exactly, as you well should, because that's going to be an exciting game. Actually, this year it may be an exciting game.
LSU
Yeah.
really
They're not playing this year.
Other than that,
No.
I certainly appreciate everyone's participation. And if you enjoyed yourself, we will send out a survey in the next day or two to see to get your evaluation on on tonight and how it went. We had 39 people actually that were registered for the conference, and a lot of them were international. So a little surprised they didn't show up. But we appreciate your participation, and please let us know what other topics you would like to hear about. What else? The McSwain Trauma Education Project is here for you. So let us know what we can do for you and what you're interested in. And Andrew and JP and iPhone, we certainly appreciate your participation.
One question I have of the participants.
Yes,
Lance
sir.
and I actually called each other and talked about, do we give semi-lectures, or in a debate, do we use slides to support our side? We made a conscious decision not to use slides and not to have a bunch of numbers and charts, and but we would do it the way you saw it done. So I would like people to say, I want more slides, I want fewer slides. I like the way you did it. I thought the way we did it, let it be wide open and not hung up on, I have to present these damn slides because I prepared them. So let's hear from you on what you like.
Yeah.
I was coming in.
I'm gonna weigh in on that. I think that an open discussion such as this is more valuable than any type of slides that's in there. I think it's more meaningful in there. And again, I think it has a more true reflection of what's going on in there, and the thought process that goes along with that, as opposed to a prearranged presentation in there. I would like to see more open discussions such as this.
And it's about the participants. It's about the participants and being a part of the discussion, which is what we're really looking for as well, to Steve's point, and to Dr. Mattox. Thank you, Dr. Mattox, for being here. We're very privileged that you were here. To Dr. Stuke as well, same thing. Dr. Cromer, it's always great to see you. And Steve, it's always great to see your handsome, smiling face. And then if you like tonight, then please let us know, and please let all your friends and family and social media, let them know. We will not have, not charging for at least the next year. We just looking for participation and people to get involved. We're not about making money. We're about education. So this is the McSwain Education Trauma Project, and we appreciate you being here for the third Thursday Trauma Talks. Thank you so much.
Since Dr. Maddox has gone off screen, has he already taken his coat and tie off?
Yeah.
I have.
Yeah. Hey, Marion, also, if we could just get a plug into the idea that, again, on October 14th, there is an MTEP or McSwain Trauma Education Project conference going on in Omaha. That's a one-day conference that does have a lot of national speakers in there. That's a good topic. And then there's another one scheduled for December in Cancun, Mexico, if any of you are looking for a little a reason to get out of the cold weather during that time. So again, please take advantage of it. Visit the website for MTEP, McSwain Trauma Education Project. and you can see the registration process out there and become part of that project. And again, I'd encourage what Mary was talking about. Please send us suggestions on any other topics that you'd like to see discussed on these third Thursday trauma talks in between there. Again, it's our privilege to try to create things that are needed out there, that you need, as opposed to what we think you need in there.
Indeed, and that's what the conference, or the McSwain Trauma Project is all about, is what are your educational needs, and we are here to meet those. Thank you, Steve.
Thank you.
Good.
Y'all have a nice evening.
Good
Enjoy
night, everyone.
enjoy the fall is coming. You can smell football season.
It's good to see you all again.
Bye-bye.
Absolutely.
Everybody have a
Thank you,
good
Dr. Maddox. Thank you, Dr. Stuke, for being here.
Thanks, Dr. Mattox. See you later.
Thank
Bye.
you.
Bye.
Great. Thank you for joining us.
Thanks, guys.